Good afternoon, everybody. Thank you very much for joining us. Thank you very much to Ash there. So I'm going to take the baton now, and we're going to talk about the role of chronic pain in these types of cases. So first of all, we'll talk a little bit about pain, some of the definitions. We'll talk a little bit about physiology. And then we'll dive down into a pain report and just cover some of the sorts of topics that we look at there, and then questions for both of us at the end. So what is pain? Pain is defined as an unpleasant sensory and emotional experience which we primarily associate with tissue damage or describe in terms of tissue damage or both. Now, clearly, that's quite a mouthful as definitions go. Generally speaking, we say that pain is whatever the patient says it is. In these types of cases that Ash has been describing, these are neuropathic type pain issues. So the patients have very florid language to describe it. They'll be talking about sharp, cutting, burning, stabbing types of pain. It's continuous. They have very high pain scores, and it's often associated with a lot of disability. When we look at pain generally, the time course is either acute pain, which is less than 3 months, or chronic pain, which is greater than 3 months. And obviously, by the time these cases come to be seen in the medical legal setting, they're almost invariably, or they always are chronic pain cases. And there are two types of pain. There's nociceptive pain, which is where the nerve signaling pathways are intact and working, and there's this beast neuropathic pain where there's damage and or dysfunction of an element of the nervous system, and that's where the patients get these very florid descriptions of pain. If we look at the pain physiology, well, if we look at the textbook sort of stuff, it's full of different sorts of nerves, neurons, there's receptors, there's end plates, there's subtype receptors, there's pathways in the brain, and it does become extremely complicated. So hopefully, in order to simplify it a bit and give you a slightly more palatable and understandable version of pain, hopefully we can do that with this little video. Famous last words. It works. So basically, here we have a nociceptive input. So in this case, it's a pinprick. It will activate nociceptors, and these are action potentials. These are electrical signals which are going up the A delta and C fibers, and as you can see, they're going up the nerve. They're going back to the spinal cord. This is the dorsal horn, where all the sensory information goes back into the spinal cord. And that will cause the action potential, the electrical signal, to spread. Here it goes through a synapse. So at the top part of the synapse, you're seeing these little, what we call vesicles. They're full of things called neurotransmitters, which are chemicals. They diffuse over the synapse, and then they activate the neuron on the other side, post synaptic activation, and you get an electrical signal traveling up the spine and then ultimately up to the brain. And it's important to bear in mind that in the brain, there isn't a single pain area. There are, in fact, about 5 different areas, which we can talk about later if you wish. Now, when you get a pain medicine report, this is the sort of anatomy of it. This is what I'm really looking at. A summary of the case. So what's happened? Mr. Bloggs has been involved in the index accident on XYZ date and suffered the following injuries. We look very carefully at the pre-index accident medical records. So obviously we will get these from your good selves, and we will summarize those in chronological order. Likewise, we do that with the post-index accident medical records. So from the point of the accident, what exactly happened in terms of treatment, investigations, etc. Then we have any expert witness reports. So we'll group those as claimants' expert witness reports and defendants' expert witness reports if we have any. The next section will be the witness statements. So we'll summarize those. And then we do all of that before we get anywhere near the actual history. Now, the history of the claimant's complaint, what we do before I actually see them face to face, or at the moment via Zoom, we will send out questionnaires in advance for them to complete. And in a pain history, we're really looking at things like the characteristics of the pain. So we're looking at site, character, duration, radiation, aggravating factors, relieving factors, associated factors, what medication the patient is taking, etc. We'll also get them to complete some pain questionnaires. So this is information about the intensity of the pain, how it affects various activities such as walking, standing, housework, etc. And then the main reason for bringing the patient to the assessment is really the examination. And the way I divide up our examination is I'll do a general examination. So that'll be looking at the patient's gait, their height, their weight, their BMI. Do they have an antalgic gait? Did they bring a stick? Are they in a wheelchair? Did they bring a friend or family member with them, an interpreter, etc., etc.? So all the general aspects of the examination. And then we would do a targeted examination. Now, thinking back to the cases that Ash has presented us with, those patients more likely than not would be presenting with either neuropathic pain, nerve-based pain, or a combination of neuropathic pain and nociceptive pain. So some nerve pain, but also some musculoskeletal pain. And so we do a targeted examination of the limb. And in that, we would inspect the limb and have a look at it. Obviously, in those cases, you're going to have a well-healed surgical scar. You may have scars from traction pins, scars from other surgery, scars from the debridement, etc. And we would then look to do a targeted neurological examination. So, for example, doing light touch sensation, pinprick sensation, palpation of the limb. Usually, if the issue is on one side, we would compare it with the other side, the good side, as it were, because that's very useful. And certainly in those compartment syndrome cases, you may well see thickening of the skin, discoloration of the skin. And when you do the light touch and pinprick sensation, often within the skin graft itself, it's reduced, but certainly the areas around it, you may have an increase in light touch and pinprick sensation and hypersensitivity associated with that. We'd also do a general neurological examination. So that would include tone, power, reflexes, examination also. And then when the patient's with me, I also ask them further questions. I've got a big list here, which I don't propose going through the list, but I essentially go through the information that they've given me, but ask them to elaborate if necessary. So we talk about the accident, a summary of that, some of the psychological issues they've had, the pain issues, what medication they're on, what treatment they've had, etc., etc. So a lot of it they've already given to us, but it just helps fill in any gaps or cracks in their history. And obviously, the thing that you guys are most interested in is the conclusion. Once we've got all the information together, we've done the questionnaire for the patient, we've put it all together, we've examined the relevant areas. You want to know what we think about the whole thing. So for pain cases, the first place we start is the pre-index accident summary. So here, I will divide up into pain-related entries before the accident, any psychological or psychiatric entries, and any other health issues. When you're dealing with the sorts of cases that Ash has presented to us, very often these are young, fit, healthy males, you know, road traffic accidents, motorbike accidents, that sort of thing, and they may well not have any pre-index accident issues. But in other cases, certainly you may have patients with quite significant pre-accident pain history, and they may also have significant psychological issues. And the commonest we see are problems with anxiety, problems with depression, maybe problems with substance abuse, etc. And the reason we look at all of that information is because very often that may make those issues may make a patient more vulnerable to the development of chronic pain following a particular accident. We then look at the index accident itself. So often the instruction that you send us will contain a good account of the actual accident itself. We'll also look at the contemporaneous records to look at information specifically regarding the accident. And then, as I said before, we always ask the claimant to describe the accident, and that can give us further information. What we're also finding nowadays is patients or solicitors are able to forward copies of either footage of video or dash cam cameras and that sort of thing, and that can all be extremely useful information. We then look at the post-accident medical records and a summary of that. And what I'm very interested to know is what happens in the immediate event, in the immediate post-accident event. So as you can see, again, with the sorts of accidents that Ash has presented, these are the sorts of cases. They're not cases where the patient is knocked over, gets up, goes and has a cup of tea, wanders over to their GP a couple of days later. Often these patients are critically injured. They can sustain life-threatening injuries, including to their chest, head injuries, etc. They may well be air ambulanced or certainly ambulanced to a trauma centre, and they often have more than just orthopedic injuries that are picked up. So we need to know about the immediate medical attention that the claimant has received. And then we need to really look at the evolution of the pain and other symptoms. And again, that will be in the records, and you can work out a timeline of how pain essentially evolves. We look at the reliability and veracity. Now, certainly this will be looking at inconsistencies within the medical records, patients presenting very late, or as has happened to me not last week, a patient absolutely convinced that their pain is on the left side when all the medical records say it's on the right side. And we just need to be absolutely clear that there aren't any inconsistencies, and if there are, we need to just highlight them to make sure that we've taken those into consideration, because obviously the issue there may be that conscious or unconscious exaggeration may be to play. So we do address that. We also discuss the fear avoidance model of pain. Generally, if somebody's involved in an injury, they may experience pain. This is on the right-hand side of this slide. If they've got low or no fear, they will confront it and ultimately recover and get better. With fear avoidance, they're injured, they have a pain experience, they may catastrophize about the pain, which leads them to a fear of movement because they fear they're going to re-injure the area. They may be hypervigilant, and they may start to disuse the limb and become increasingly disabled and start to develop more psychological issues, particularly depression. These things feed into the experience of pain, and the claimants can rotate around this fear avoidance model of pain, where they're almost trapped within their pain and the experience of it. So the sorts of pain issues that we see, again, going back to Ash's presentation, certainly neuropathic pain would be very high on the list of possibilities for somebody who's experienced an injury where they've then gone on to require a fasciotomy, and they will describe neuropathic pain. They may well also have some nociceptive pain, and they may have pain in the adjacent joints, in the knee joint, in the ankle joint, etc. And some of these patients have a mixture of nociceptive and neuropathic pain. So it's not either one or the other, but there's a mixed picture. And there are the ICD, the International Classification of Disease, has classifications for the different types of pain. We then look at the range of opinion. Now, broadly, in pain medicine reports, we divide this into three. There's a organic or biological range of opinion. So the patient has nociceptive pain, or they have neuropathic pain, or they have a mixture of pain. But also, is it possible that they have arthritis or gout or some other organic cause for their pain? We then look at psychological or psychiatric issues. And again, a lot of these cases, the patient may be multiply injured or have received other life-threatening injuries. They may have also had a head injury. And certainly high on the list are things such as anxiety disorder, mood disorder with depression, PTSD, and other conditions. And increasingly we see being diagnosed by the psychiatrists is a condition called somatic symptom disorder, which if we have time, we can discuss it a bit more at the end. And we also have to bear in mind that there are non-biological and non-psychological causes. So from time to time, we will see cases where no biological or organic cause can be elucidated. No specific psychological cause can be elucidated, and the possibility of malingering or conscious exaggeration can be raised. So thinking about the biopsychosocial model of pain, in simple terms, we can't just look at patients' reports of pain and say, oh, that is their pain. It needs to be on the background of psychosocial issues. And if we look at the biopsychosocial model of pain, post-accident, patients will have biological pain, so they may have neuropathic pain or nociceptive pain or a mixture of those pains. They often have psychological factors, which we've alluded to earlier, such as depression, anxiety, fear of travel, PTSD, etc., etc. And there may well be a lot of social factors. So they may have lost friends, family don't speak to them, they're reclusive, they've lost their job, they don't engage in the sorts of activities and hobbies that they used to. And so you start to build up a much broader picture of how the accident, which has caused the pain and the psychosocial factors now come together and show how that claimant is now presenting in this biopsychosocial model. When we come to causation, very often claimants have been seen by orthopedic surgeons, by psychiatrists, and in some cases neurologists. And in these cases, certainly the primary expert would be an orthopedic surgeon. So the first thing to be said in the causation is I defer to the expert witness in orthopedic surgery regarding the causation of the claimant's orthopedic injuries. And we would always do that. Likewise, if there has been a psychiatric opinion, we would defer to that and any other opinions, and then we would state what we thought. So on the balance of probabilities from a pain medicine perspective, what we think has been the cause. And generally it will be the index accident that has caused the issue. We also look at prognosis. And again, as we discussed earlier, by the time these claimants come to their medical legal reports, it's often many years and many months have elapsed since the index accident. And as a sort of blanket statement, we can really say that on the balance of probabilities, the claimant's pain is unlikely to spontaneously resolve. What does that mean? Well, that means that when Mr. Jones has been involved in the index accident, and he got compartment syndrome, and he has neuropathic pain affecting his left lower limb, and it's now 5 years on since the index accident, the likelihood that he will wake up one morning and his pain is miraculously disappeared is unlikely. So once you get to that point, that pain, after it gets past 3 months, as we said at the beginning, after it's now chronic pain and not an acute pain problem, the likelihood that it will spontaneously improve diminishes as time goes on. And as the last part of the prognosis would be on the balance of probabilities, the claimant's pain will continue indefinitely and therefore can be considered permanent. And generally speaking, with these cases, if the claimant presents to you with pain, whatever type of pain, let's say 4 or 5 years after an index accident, without any further treatment, it will continue and be a permanent issue. So let's look at treatment overview. So a lot of these cases, and when I say these cases, the cases that Ash has presented will require a multidisciplinary team approach. So it's no good giving patients a few tablets and sending them on their way. You would need multiple experts in their fields within usually a pain clinic environment to treat the patient. Generally speaking, treatment starts off with pharmacological treatment, and certainly discussing neuropathic pain, the mainstay of treatment is to try and get the optimum anti-neuropathic medication, that is medication used for the treatment of nerve pain. And up here are the 3 most modern agents that we use. So that is pregabalin, gabapentin, and duloxetine. Amitriptyline is an older drug. We also use multimodal analgesia. So we may use multiple different types of medication with different mechanisms of action overall to produce a therapeutic benefit, i.e. reduction in pain. Psychological treatments, as we said, a lot of these patients will have either head injuries or will have quite significant psychological issues after the accident, particularly if it's been life-threatening. And they may well require clinical pain psychology, counseling, CBT, EMDR, and other techniques. From time to time, we will suggest minimally invasive pain management techniques. So a lot of these are done either under ultrasound or X-ray guidance. And in the example of the patient with neuropathic pain affecting the lower limb, we may, for example, do treatments such as pulsed radiofrequency to the nerve roots in order to reduce the overactivity of the nerves and reduce the pain. Or we can we can use Botox either for neuropathic pain directly, or if patients have a lot of muscle spasm and they have, for example, myofascial pain or trigger points. In some of these patients that Ash has presented, they may well go through conservative multidisciplinary treatment. So they get the medication, they get the physiotherapy, they get the psychology, they get an injection, but they still have ongoing severe pain. And in some of these cases, they may be amenable to advanced pain management procedures. So this would be something like a spinal cord stimulator, which is an implanted device where we put electrodes next to the spinal cord and use an electrical stimulus for that. Now, the last treatment I've put here is deliberate. I've put physical therapy here. And the reason I've put this is because in my practice, and in most of our practice, the reason for all the treatments that we've discussed, all the injections, all the medication, etc., is essentially to try and create a pain-free window in order to allow our patients to rehabilitate, and that is physical rehabilitation. It tends to be undertaken by specialist pain physiotherapists, and it includes a physical rehabilitation program, a graded exercise program, strength and flexibility training, use of a cross trainer, and overall we're trying to gain functional improvement for the patient. We also look at current activities of daily living, specifically what the claimant's able to do now around the home, and their current employment. And regarding employment, generally, we encourage employment. It's part of the therapeutic process, certainly treating patients with a view to returning them to the workplace has psychological benefits, physical benefits, social benefits, and financial benefits. So often a very important endpoint for treatment is to improve a patient's pain, improve their function with a view to a graded return to employment. Now, obviously, as Ash has discussed, if you have patients who have predominantly manual type jobs, this can be very difficult, particularly if they've had lower limb injuries, significant injuries. And it may be that the patient may need to look at changing their job role or to a more sedentary role, and maybe looking at part-time working. We also look at the patient's future care requirements. Now, this is very important. Obviously, we can report on what the care requirements are at the moment and whether they need help with gardening or DOI or et cetera, et cetera. But in these cases, it's important to have a view on what the future care requirements are going to be. The important thing here is that we always recommend that patients conclude litigation, and then they undergo further multidisciplinary treatment, which usually takes about 6 months, 6 to 12 months at most. And one of the aims of treatment, as we said, apart from pain relief, increased function, and a return to the workplace, is going to be to increase the claimant's independence and reduce their care requirements. So what we never want to happen is, unless it's necessary, is for patients to have very significant packages of care. We really want to encourage patients to be as functioning as possible, and to minimize their disability as much as possible, and to minimize their care requirements so they're able to do more. They're less reliant on other people, they're less reliant on outside care, unless of course that's necessary. When we have patients who do have what we would call complex care requirements, then it's usually important to get an expert witnessing care to look specifically at the care requirements in more detail. Surveillance, well, I'm not going to say anything about surveillance. We can talk about surveillance till the cows come home at the end, if you wish, in the question and answer. Suffice to say, I would say that the vast majority of the surveillance footage that we see doesn't cast any really serious doubts on a claimant. However, having said that, there's no doubt that there is surveillance footage that we see which very strongly makes us consider whether or not the patient has in fact been entirely honest with us. And obviously, when that sort of surveillance footage comes out, it has to be dealt with appropriately when that happens.